A very good afternoon, everyone. It is my pleasure to welcome you all to the 10th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center for Excellence for Tuberculosis. The clinic is dedicated to challenging cases of pediatric tuberculosis. Tuberculosis remains one of the most pressing global health issues in children and is associated with complexities in diagnosing and treating TB in pediatric patients. I welcome directors and team from NIIT, NTI, STOs, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, TB pediatricians, and everyone present today. Without further delay, let me introduce the faculty from NITRD. I am Dr. Dhulika Dhingra, Specialist Pediatrician at NITRD, and I will be moderating today's session. To my right is Dr. Sangeeta Sharma, Chief in Charge, National Center of Excellence and ex-Director, NITRD, New Delhi. And to my extreme right is Dr. Alok Yadav, CMO, NFSG. I now would like to welcome and also request our director, Dr. Manpreet Bhalla ma'am, to give her inaugural address. Over to you, ma'am.
Thank you, Dhulika, and good afternoon and welcome everyone to this National Pediatric Center of Excellence for TB, which is being held in collaboration with the Regional Pediatric Center of Excellence for TB, as well as the National Pediatric Center of Excellence. I welcome Professor Dr. Urvashi V. Singh, DDG TB, who is always present to give her technical inputs and guidance and support as always. I welcome Dr. Ashok Bhardwaj, Chairperson of NTF, who has also joined the meeting. And today's topic, the case presentation will be from Sassoon Hospital, Pune, as it is mentioned. And the topic will be diagnosis of MDR TB. So as we all know, and the lessons learned, so diagnosis of MDR TB is very difficult in adults also, as well as more so in children. So I welcome everyone, and look, I think we can go ahead with the case presentation. Thank you.
Thank you, ma'am. I would now request Dr. Sangeeta Sharma for her remarks. Over to you, ma'am.
Yeah, welcome all. So this is our second year running, and thanks to all of you who have joined in. And without wasting time, now I'll request our DDG TB, Professor Dr. Urvashi Singh, who is joined with her team. We all know Dr. Urvashi. She's a distinguished microbiologist working at AIIMS and who has got extensive experience, especially as regards to diagnosis of TB. So, Dr. Urvashi, a few words from your side will be a blessing for us. Dr. Urvashi, please.
So, good afternoon all. Namaskar. Thanks to NITRD for the continued efforts to maintain the continuing medical education throughout the country. So, I must thank the current and the ex-director, Dr. Manpreet Bhalla, who's the sitting director, Dr. Sangeeta, who was the previous director, and of course the legacy that NITRD has always maintained. But maintaining this legacy is an uphill task, and we, have a lot of trust and faith in NITRD, and also, it's a challenge for them. So this CME that Dr. Sangeeta Sharma has, contributed to so significantly over the past 2 years, and the support of the National Task Force and Dr. Bhardwaj sir. The efforts towards treating MDR TB in children are actually being fructified, if I may put the word. Globally, there are trials which are trying to shorten the treatment. And let me also say that Dr. Sangeeta Sharma has taken a lot of initiatives in several research studies where she's also contributing to new treatment regimen, treatment shortening, and so on and so forth. But treatment shortening is a tricky trade, because if we work on shortening the treatment and we lose on, say, for example, recurrence-free cure, if there are recurrences due to shortening of treatment, even though we may be using the best of treatments available to us, the best of the latest drugs available to us, we do not want to compromise on recurrence-free cure, especially in our country, because if there's a recurrence and we miss it, then it's possible that there may be a delay in diagnosis and delay in diagnosis of the drug resistance. Hence, whenever we talk of treatment shortening, it is a difficult proposition to adopt a treatment shortening regimen under the program when it is meant for the masses, where we want to ensure a regimen which will always ensure complete cure, and preferably a cure which is recurrence free. Or so in children, of course, there have been the new drugs. We have ensured bedaquiline for children. The laminate is being now prescribed. Pretomanid was not recommended for children for there's enough published evidence for now. We are not recommending it. The combination regimens which would help us shorten treatment of MDR-TB in children are being worked on. Like I said, Dr. Sangeeta is also working. So soon we will also have a shortened treatment regimen for MDR-TB. And till such time, we continue to follow, and I'm sure Dr. Sangeeta will be able to reiterate the current regimens that are available to us, and how we can improve upon them going forward. But as you're aware, for the BPAL-M also, there was enough in-country evidence, enough evidence to show the treatment success rates, enough evidence to show that recurrences were kept to a minimal. In addition, we took into account the global evidence and designed the best regimen possible for our population. So similarly, we'll proceed in the case of children. We will take enough care so we come out with the best regimen possible, even if it means it will take some time, but we will get there. So thank you so much to all the participants who have taken the time out to attend the CME. And thank you to NITRD, Dr. Sangeeta Sharma, and of course, Dr. Manpreet Bhalla for this lead. Thank you, Dr. Bhardwaj, and I think we can proceed. We can discuss later. Thank you.
Thank you, ma'am. The pre-test link has been shared in your registered email. Please attempt. Moving on to today's case presentation. Today's case is from Department of Pediatrics, BJGMC and Sassoon General Hospital, Pune. Dr. Shreya Joshi, postgraduate student, second year from Department of Pediatrics, will be presenting today's case. Dr. Pragati Kamath, Associate Professor from Department of Pediatrics, Sassoon Hospital, will serve as the case expert for today. The national expert for today's session is Dr. Sangeeta Sharma. Now I request Dr. Shreya to please start with your case presentation. Over to you, Dr. Shreya.
Good afternoon, everyone. I shall be beginning my case presentation. I would like to start sharing my PPT.
You can.
I hope my screen is visible to all.
Yes, your screen is visible. You can start the slideshow. Yeah, that's fine. Please go ahead.
Yes, ma'am. So my case is a 16-year-old female. She goes to class 10th. She's a resident of Ravet, Pune, first by birth order, born out of a third-degree consanguineous marriage, Hindu by religion. She has a normal birth history, who has achieved all developmental milestones and an appropriate age, completely immunized, and belongs to the class 2 socioeconomic strata as per the modified Pupuswamy scale. She had come with the complaints of cough, fever, loose stools associated with abdominal pain, backache, and these complaints were on and off since 24 months. I would like to highlight here the timing that it all began in June 2022. So this patient was apparently all right till June 22 when she developed cough with expectoration. This was insidious in onset, minimal in quantity. It lasted throughout the day, and the bouts of cough were gradually increasing in intensity. There was one episode of blood-tinged sputum, which was non-foul smelling. However, there were no aggravating or relieving factors as such. Also, there were no diurnal or seasonal variations. The patient also complained of fever, which was low grade and continuous in nature. It was documented as high as 101 degree Fahrenheit, which was associated with chills and rigor. The patient also complained of an evening rise of temperature, and there was a generalized body ache. The patient said that it was more on the right side. However, it was relieved on taking oral antipyretic medications. It is also associated with a history of weight loss. The patient tells that 8 kg was lost in a period of 2 months. This was followed by pain abdomen. The patient said that it was a cramping sensation which was more in the right hypochondrium and the right iliac fossa, but there was no shifting of pain. It was not referred or any radiating nature of pain was seen. This pain abdomen resolved spontaneously for a few hours. The patient also developed loose stools, which were 6 to 7 episodes per day, semi-solid in consistency, not associated with any worms or blood, and this was also relieved on taking oral medications. So our patient had the following complaints, but there was no complaints of abdominal distension, constipation. There were no urinary complaints as such in the form of poor stream, burning micturition, or strangury. The patient did not complain of any GI bleed, hematemesis, or melena, or there was no complaints of hematuria as well. As far as the fever cough cold is associated, the patient did not have any chest pain, difficulty in breathing, runny nose or ear discharge, and there is no complaints of rash, joint deformity or arthritis. For the above mentioned complaints, the patient received oral medications for 2 months from the nearby local clinic, and with the use of such drugs, there was some relief present, but these symptoms continued to recur. So, for the complaints of pain abdomen, the patient went ahead and got a USG A+P done on their own request. It was suggestive of abdominal lymphadenopathy. Based on this report, the parents took the child to a clinic or a hospital for further management. Based on the long course of these complaints, they were advised admission. For the complaints of fever, cough, cold, they thought that it might be presumptive COX and a sputum CB-NAT was advised. In July 2022, the report was found as MTB detected medium with no REFA resistance, and AFP was 2+ on the ZN stain. Based on this report, AKT was started. It was 2 months of HRZNE it was given. The patient also got a chest X-ray done, the films of which are not currently available, and MON2 was negative. Now, the first lesson that I would like to tell is that no fixed drug combinations were given to the patient. They were told to procure it on their own from a private medical store. There was no relief from these medications, so the patient was shifted to another hospital. In the second hospital that they went, monthly follow-up was taken. However, end of IP investigations were never done, and the patient was told to continue HRNE for a period of 16 months. That is from August 22 till November 23. The patient took HRNE, that is isoniazid, rifampicin, and ethambutol. So based on this, the patient has now taken 18 months of AKT, and in November 2023, AKT was stopped in view of radiological improvement. Serial HRCTs were done in which the size of the mediastinal lymph nodes, initially in the month of August, they were 4.3 into 1.9 centimeter in size, and then in November 23, the size had slightly reduced to 4 into 1.7 centimeter of mediastinal lymph nodes, and few mesenteric lymph nodes were also present. The patient was then advised a drug-free period from December 23 to February 24. The another mistake or a lesson that we should take into consideration is that clinical evaluation was never done properly and importance was only given to the lab findings. During this drug-free period, the patient was still symptomatic. The parents said that the patient still had fever, vomiting, nausea, and pain abdomen. Now this pain abdomen had started radiating to the back. As we can remember, initially, the pain abdomen was not associated with any radiation. Because the parents were worried, they again went ahead and did a USG A+P done to see why the child is still symptomatic. And in April 2024, a USG was done, and it was found that there were subcentimetric and few heterogeneously enlarged mesenteric lymph nodes in the right iliac fossa. the largest of which was 24 into 10 mm in size, approximately 2.5 centimeters. With these reports, they took the patient to another hospital where the child was advised admission. Now, because the backache was increasing in intensity, an MRI spine was done in the hospital to rule out dissemination. The report was that there were soft tissue signal intensity lesions in the prevertebral region, mainly in the D5 to D7 levels, likely lymphadenopathy. However, scattered nodules were also seen in the bilateral lung fields. Based on this report, they were again told to get a PET CT scan done in the month of April 2024. It was found that there are metabolically active bilateral lung, parenchymal, pleural-based nodules, active mediastinal and mesenteric lymph nodes with active peritoneal thickening. These features were suggestive of an infective etiology. So we can see that multiple investigations have been done till now, but the patient is still symptomatic. So based on the PET CT scan and the USG reports, on 7th May 2024, a CT guided true cut biopsy of the right iliac fossa lymph node, which was 24 into 10 mm, it was done. And I have included the reports as you can all see. On the histopathology, it was seen that there is granulomatous lymphadenitis with areas of necrosis with no evidence of parasitic or fungal elements and no evidence of malignancy. So with the areas of caseous necrosis, it was highly suggestive of COX. On the same sample, special stains were done. They did PAS stain, ZN stain, and Gram stain, which were all negative. They also did a culture and sensitivity report on that same sample where no growth on aerobic culture was seen after 10 days of incubation. Proceeding further, MGIT culture was also done where no growth was isolated after 8 weeks of incubation. However, we come to an important report. Expert MTB or RIF Ultra was done, where MTB was detected with RIFA resistance not detected and an organism load very low. This is the same right iliac lymph node biopsy sample. Further ahead, MTB pyrosequencing was done. MTB was detected. INH resistance to CAT-G was positive. However, fluoroquinolone resistance GYRA and RIFA resistance in the form of RPOB, they were not interpretable. I would like to emphasize here that even though the sample was positive, an LPA was never done. Directly, a higher and a newer modality of pyrosequencing was done on the same sample. We could never find the sample and the LPA reports. So based on these reports, the patient was started on linezolid, cycloserine, ethionamide, clofazimine, monopass, and benadone. I would like to say that drug-resistant regimen was started, even though, as we know, that RIFA resistance was not detected in the report that are attached. Within 2 days of starting these drugs, the patient developed 10 to 12 episodes of loose stool and 5 to 6 episodes of vomiting. The patient was then advised a drug-free period of 2 days and was told to continue only linezolid and cycloserine and to discontinue the rest of the AKT. Pre-treatment evaluation, as is mentioned in the NTP guidelines, was not done for this patient. Directly, drugs were prescribed. On 21st May 2024, the AKT was again changed to cycloserine, levoflox, clofazimine, and pyridoxine. These drugs, as we can see, were prescribed very haphazardly. NTP guidelines were not followed. So now the patient came to us in the TB OPD of Sassoon General Hospital in June 2024. So she had now come with the complaints of nausea, bloating, multiple joint pain, along with headache. Against a background history of intake of prolonged AKT drugs, the patient had already taken 18 months of drug-sensitive TB along with MDR TB drugs in a sputum-positive, drug-sensitive pulmonary tuberculosis. The patient otherwise has a normal menstrual history. There is no significant family history that I would like to share. On examination, the child is fine. There is no peripheral stigmata of tuberculosis. This is the IAP BMI chart. The patient falls well into the category between overweight and obesity. We also did an examination of spine where PGALS was also done. However, it was all within normal limits. Systemic examination, there were no specific findings. So we again continued to do a complete pre-treatment evaluation for the patient. No significant findings were found as such. In our USG, we found that there was a simple right ovarian cyst with minimal interbowel flea fluid and subcentimetric lymph nodes. Sputum was again sent for gene expert from our side and MTP was not detected. This is the X-ray that we did for the patient. We also repeated other investigations. Considering the prolonged history of joint pain and backache, we ruled out ANA, anti-CCP and ANA blot investigations were done. These reports were found to be moderately positive for ANA, and ANA blot DFS 70 was strong positive. We took a rheumat reference for the same, and it was advised that these may be falsely positive in special situations. So based on the above clinical history, examination findings and investigations, we classified the patient as H. poly, drug resistant, disseminated tuberculosis, INH and fluoroquinolone resistant, and REFA sensitive, taking into consideration both the pyrosequencing and the expert report. The patient was started on 9 months of AKT as per the weight band 46 to 70 kg given in the guidelines. And from August, 6th August 24 till 5th May, the patient was advised to start linezolid, rifampicin, ethambutol, and pyrazinamide. Monthly follow-up along with high protein diet was counseled to the parents, and possible adverse events were also explained, and they were told to come and follow up on a OPD basis. However, considering the extended use of drug-sensitive medications for 18 months with no response, and the use of MDR drugs with no prior pre-treatment evaluation, and the patient was still symptomatic intermittently, we sent therapeutic drug monitoring levels on 16th September 2024 when the patient came for us to follow up. It was found that the levels of rifampicin, ethambutol, and pyrazinamide were in the subtherapeutic level. They were way below the normal range that should have been there. So, based on these reports and the TDM levels, the patient was now started on 4th October on a bedaquiline-based longer oral regimen that included bedaquiline, clofazimine, cycloserine, linezolid, delamanid, and pyridoxine. The patient now comes for monthly follow-up, and till now, the investigations that we have concluded, CBC, ECG, all the monitoring, they are within normal limits. The patient is on regular follow-up at TB OPD at Sassoon Hospital, Pune. She has no active complaints. All the complaints of nausea, vomiting, joint pain have significantly improved. The patient has good drug compliance and is now clinically and vitally stable. To summarize my case presentation, I would like to say that fixed drugs combination should be given free of cost, as are advised in the national program. Stepwise algorithm should always be followed while making a diagnosis or a treatment protocol. A patient comes first, so we should treat the patient and not the reports. Counseling of parents is a must. This is one issue that we faced during the diagnosis and the course of the illness for the child, that the parents were so frustrated that they had been to multiple hospitals. The child had already taken so many medications for such a long time. So proper counseling of both, as she is an adolescent patient, and the parents is very must. And gradual implementation of newer modalities like pyrosequencing are needed to move ahead with the times. Thank you.
Just to summarize this case, we can summarize the case as follows. So a 16-year-old girl child was symptomatic since June 2022. So she had presented to BJMC and Sassoon Hospital in June 2024 with complaints of cough, fever, loose stools, abdominal pain, backache on and off since June 2022. Child was initially worked up from a private clinic where investigations had revealed AFB2 positive in the sputum, and sputum NAT had revealed Mycobacterium tuberculosis, medium load, and rifampicin resistance was not detected. On the basis of this report, child was started on ATT, which was non-DOTS, which was continued for almost 18 months, from June 2022 to November 2023. However, in view of persisting symptoms, a repeat ultrasound was done by parents on their own, which revealed mesenteric lymph nodes 24 into 10 mm in April 2024. At this time, a PET-CT was also done, which had revealed metabolically active bilateral lung, parenchymal, pleural-based nodules, and active mediastinal and mesenteric nodes, and active peritoneal thickening, which was suggestive of an active infection. The iliac fossa lymph node biopsy was done in May 2024. The biopsy had revealed caseous necrosis and with the granulomatous lymphadenitis. The gene expert ultra, which is not a NTEP approved test, was done on this sample, which detected Mycobacterium tuberculosis. The load of the organism was very low and it was RIF sensitive. TB pyrosequencing was done on this same sample. Again, it is a test which is not approved by NTEP. It revealed H resistance. Rifampicin and FQ results were not interpretable. This is an important finding here. The child was started on reserve drugs, which was not a NTEP approved regimen haphazardly. And when the child was not tolerating these drugs, the child was brought to BJGMC Hospital, Pune in June 2024. At this time, the child had a BMI of 25.8. There were no peripheral stigmata of TB, and Tanner stage 5 was seen. So this child was classified as H polydrug resistant disseminated tuberculosis, INH and FQ resistant, and RIFA sensitive. Here, I would like to ask the treating team that we have already mentioned, you have also mentioned in your case presentation that TB pyrosequencing is not an approved test. We all know that. So why on the basis of, how on the basis of this test, we classified this patient as H polydrug resistance? Because the rifampicin and FQ results were not interpretable on the basis of the TB pyrosequencing. First, this is not an approved test. Second, the results are not interpretable. So how this patient was made a H polydrug resistant case, and further, we see that this child was started on the regimen linezolid, rifampicin, pyrazinamide, and ethambutol. Considering the prolonged exposure to ATT or for almost 18 to 20 months, TDM was planned, which revealed low drug levels for rifampicin, pyrazinamide, and ethambutol. And when the levels came low, the child was shifted to an all-oral MDR or rifampicin resistant TB regimen. Here, I would also like to ask the team, did they consider increasing the dose of the drugs here before shifting to an all-oral longer regimen, the MDR regimen? Yes, I think you can... Aditi, if you would like to highlight these points, you would like to put some light on this?
Ma'am, can I... Dr. Pragati here.
Pragati, we can hear you, Dr. Pragati.
Ma'am, actually, we went through the drugs which she had consumed earlier, like the separate drugs and not the FDCs which were given to her. We saw that she had taken these drugs in the right doses. So it was not a suboptimal dose which was given to her, although they were a separate drugs that were given. So that is why we did not re-challenge her with rifampicin, because she had already taken almost 16 months of rifampicin. And this sample which was taken was from the right iliac lymph node. And when we investigated at her at our place, we did not have any sample, like we did not, even our sputum did not come out positive, or we did not have a repeat lymph node sample which we could access so that we could test it for other tests like LPA. So we believed the report of, we trusted the report of, we erred on the side of the pyrosequencing report and considered that there was levofloxacin resistance which was not interpretable, and that is why we considered as a poly resistant TB, because the patient had already taken 16 months of treatment, and so we wanted her to start her, and the parents were very distressed. So that is why we started on this regimen and did not re-challenge her with rifampicin again.
Here, if you would see the ultrasound that you have shown, does not show any lymph nodes that were shown in the ultrasound on done on April 2024. And
Yes.
the child has also gained weight. She has a BMI of 25.8.
Yes, she has been healthy, like a little on the healthier side from the beginning. So that is why maybe in the previous setups where she was investigated, they did not think on terms of multi-drug resistant tuberculosis, or that she was a not responder. So that was masking her weight was probably one factor. She did not look like a patient who had tuberculosis. So that might be masking all those people were not thinking on side of, she might not be a not responder.
I'd like to ask you a few questions, regarding any confirmation about the dose or the compliance with the first line ATT was given. Because that
Yes,
time it was, confirmed through NAT, although first and second line LPA were not done. So for
yes,
the information of the house, whenever the smear is positive, and with children, this may be the only chance. So it's always better to go ahead with first line LPA, even second line LPA. Although for adults, we say that go ahead with the second line LPA if the first line LPA shows RIF resistance. But in children, I would say, because you may not get that sample. So, before I ask you further questions, I'd like to ask Dr. Urvashi, because the microbiologists are the persons who will come to our rescue over here. We have heard over the case, and just want your input. Dr. Urvashi, now this child, what I presume from the team, is the child symptomatically better? Any fever the child is running, because the child is overweight, and I mean, is the child having any fever?
No, ma'am. Since
There is
he's
no
getting
fever.
no, ma'am. The complaints of that nausea, bloating, pain, abdomen, and the backache that she was
They could
complaining.
be sequelae. I was just wondering, because there is no fever as such. And the ultrasound which you have shared, I just want to ask, because ultrasound is a subjective feeling of the clinician. So, did you get a CT done? Because the child had already been subjected to PET, etc., and they showed huge size of lymph nodes, almost like 4 into 1.2 centimeter. And over here, I mean, now the lymph nodes are not there; they are just sub-centimetric on ultrasound. So the two, they do not tally. I mean, the PET which has been done just few months prior shows that there is a lymph node mass in the mediastinum as well as in the mesentery, while the ultrasound which is repeated and the chest x-ray which you have shown, I mean, that does not show that there is any mediastinal widening or things like this. So, regarding these two things, they don't correlate, and you being the clinicians in charge, I mean, we would like to ask you, did you think of getting a repeat CT done, because the ultrasound was not showing any findings in this case? Once the PET showed so much, it had metabolically active lymph nodes, metabolically active lung nodules, and even the pleural nodules were metabolically active, which shows that there is an active disease going on. But the ultrasound, that does not match. The clinical scenario of the child does not match. The child is not having fever. The child is gaining weight.
She
Have
was
you
having she was having fever, ma'am. She was having fever on and off. She was having abdominal pain on and off. Only thing was she was putting on weight. Only after taking treatment now she's a little better. But otherwise she continued to have this on and off symptoms of fever. So that is why we thought even in terms of whether we are having a connective tissue disorder.
did you
And
get fever charting done, temperature charting done?
ma'am, the parents were, yes, they were, the father and the mother were doing the temperature charting at home.
Did
They
you
would,
see it yourself? Because
yes.
the two things, they do not correlate. That is one thing which we are quite skeptical about. That the child is running fever. The chest X-ray appears normal, while the PET scan report, which you have showed, which you have shared just few months prior to this chest X-ray, shows that there is a lymph node mass over there, and of a significant size, like 4 centimeter is a huge size lymph node. And And now would like to ask the microbiologist, especially Dr. Urvashi, for her inputs regarding the reports. We have expert ultra, which is showing very low MTB detected with drift sensitive. So I feel that this could have persisted, despite the treatment. So, okay. I'll now also, if Dr. Urvashi is not there, she had to leave for some urgent work. May I request Dr. Manpreet Bhalla if she can shed light on this, the interpretation of the reports, the expert ultra, as well as the report on the pyrosequencing. Manpreet, are you there?
Yes, Dr. Sangeeta.
Yeah.
So, yeah.
Expert.
As you said initially, the LPA should have been done obviously for INH resistance as well as the RIF resistance. Like it was said that NAT gave it as RIF resistance and Ultra gave it as RIF sensitive. So I just both the NATs, all NATs gave RIF resistance.
No. I think you did not register properly. The NAT which was done initially in July 22, that showed it was RIF sensitive and the MTB detected was medium. So we believe that report because also it was 2 plus. My only concern was when the sputum smear was 2 plus, why did the first and second line LPA, why it was not done? But otherwise, the treatment was started according to the NAT report, which is correct. But the report which is coming later on, that is expert ultra. Expert ultra, very low MTB detected. So very low can persist. That is, I want to ask from you. The utility, the clinical utility of expert ultra, once the child has already taken ATT.
Yes. So as you said that once a patient is on ATT, obviously the bacteria bacilli will decrease. So the expert ultra is very sensitive, but it is very less specific.
Yes.
So that is why it gave us very low. And secondly, also, as you said, that LP again should have been done for INH as well as for fluoroquinone FQ resistance.
Right.
And because I think they directly went to pyrosequencing and which the results were not interpretable.
So what is how do you interpret this report, of rifampicin and fluoroquinolones not interpretable? Now, how to take it as a clinician, I just want to ask you.
Yes, so just want to tell about the pyrosequencing. It was the first sequencing. It came before after Sanger sequencing, then pyrosequencing came. So the disadvantages of this that it has very short read lengths. So that is why it may not be interpretable. That was the reason. And also it has limited accuracy because of the enzymes which are used. So the accuracy is very limited. And also the data analysis is very complex. And also it is very compared to, that is why we shifted to the whole genome sequencing, which covers longer read lengths so that more genomes are covered and it can be interpreted. So this maybe have been missed because of low read lengths. So this is one of the reasons, and that is why pyrosequencing was it's not used technique now at present. So now we go for next generation sequencing and whole genome, that is whole genome and targeted sequencing. This also could be done directly on the sample as well as on the culture isolates. But again, it has less sensitivity because of the low read lengths. So that is the reason it might have been missed. So that is about the sequencing part of it.
So, the host team, they have started the child on the bedaquiline based all oral pre-XDR regimen. And you have said, disseminated TB. I mean, I would like to ask you which sites are involved? Because the chest X-ray is normal, sputum is negative, and the NAT on sputum is negative. I mean, disseminated requires at least 2 sites with with an intervening non-infected site. So I would like to ask the host team, I mean, how the diagnosis of disseminated pre-XDR has been made.
Am I audible?
Yes, please.
Yeah, I'm Dr. V. Magesh Kumar, specialized in mycobacterium tuberculosis researcher, done research in NART. This is my quick introduction. So coming to disseminated tuberculosis, already coming to this case, you reported in PET scan, clearly mentioned the mesenteric lymph node, like it is like a positive node for pulmonary tuberculosis. So probably it would be smear negative pulmonary. We have to consider. So we go for line probe assay or else gene expert. So coming to this case, gene expert clearly says very low level of MTB, whether low level, high load, everything is positive for tuberculosis. That is, we have to consider as for National Tuberculosis Elimination Program guideline. And one more thing, so rifampicin sensitive, probably we could get INH positive, and other drugs also we have to get positive. That is, we have to rule out by the line probe assay. So coming to the pediatric case, especially for pulmonary TB or extrapulmonary TB, we have to use the diagnostic algorithm, whatever says by National Tuberculosis. We are getting sputum sample from the. Yes.
Yeah. So it was expert ultra. It was expert ultra. It was not expert. So expert ultra, as Dr. Manpreet has also highlighted, it may remain positive. That is what we are trying to tell the house, because expert ultra, that is the reason we have not adopted it under the program yet, because it's a highly sensitive test, but it loses its specificity. And because it's a molecular test, and the DNA after complete successful treatment can remain. And expert ultra is a test which can come positive. And in this case, it came out very low. Expert ultra, very low. RIF sensitive.
So that's why. Yeah. So that is the thing. The coming to the gene expert and gene expert ultra. These two are it is a fully automated and a nucleic acid amplification assay.
That is
it is for bossy basal nature. We are not getting adequate basal in the particular sample. It's a bossy basal in nature. And that's why we quickly pick
up. That's okay with you?
Yeah.
Yeah, just wanted to add on. I think so, sir. Actually, I just wanted to make a comment. Dr. Bhalla ma'am has also explained, and Dr. Sangeeta ma'am, just to add on one little thing, that the dead that can remain, that we know, but in case of ultra, it can DNA almost from 2 to 5 years. There are some case reports. There are some cases where they picked up almost till like 4 years also. So anything, anyways, above 2 years is a possibility. And if you see this case here, 2022, it was medium detection and RIF sensitive. Now you come 2 years later, you find that it has become very low because the response has taken place and probably the bacteria has been picked up the same DNA, which is why it is giving sensitive. So that is the answer. And since I've got the mic, I'll also like to make one point. The question which is being asked regarding pyrosequencing, Dr. Bhalla ma'am has very nicely explained the technical part. But I'll just like to add on one only thing, that not interpretable in any of the technology means that neither an antibiotic can be reported as sensitive, nor it can be reported as resistant. So now the clinician is only left with the choice to repeat the technology. Pyrosequencing anyways is not a technology by NTP. So in that case, if nothing else, any other lab which was doing LPA should have been repeated. Here it was just arbitrarily considered as fluoroquinone resistant, which in my opinion is probably not correct. Thank you so much.
But ma'am, actually we tried getting the sample if they had any reserve sample left from the private hospital where the right iliac fossa biopsy was done. They did not have any sample left. And when we repeated investigations from our side, we could not find a significant sized lesion to again do a biopsy and repeat the LPA
So
lab.
in this case, what should have also happened, which is a lesson, which is a message to everybody, which has also been brought about by the guidelines of EPTB, that in case of precious samples, you also need to put an additional culture so that you always have a backup. And the same sample, you've done this thing. So that way, this thing could have been done. We often get cases of just the culture positives of, EP done somewhere from where we do LP or other things.
Yes, ma'am.
Yes, yeah. Again, to add, that the sample we always put up for culture. So if, as you said, there was especially for extra pulmonary samples. So if there was no direct sample available, we could have done the LPA or any test from the culture positive sample.
Yeah, but the culture, ma'am, MGIT culture, no growth was isolated
Okay.
as we saw. So we relied on the clinical, considering that the patient has taken AKT for so long and still there is no improvement, and we did not have any sample to back up on. So we thought that it is, we considered it as fluoroquinolone resistant, and then proceeded.
Yeah, but then because again it's an extra pulmonary sample, so culture may not always come positive. That is why it comes positive on a molecular, because it has a lower limit of detection. But culture has a higher limit, so that is why it may not come. So and like empirically, you took it as FQ resistance. That means it should have been confirmed microbiologically.
Yeah. To ask the host team, the patient was deteriorating clinically, yes or no? And how did you take it that the patient was deteriorating clinically? Your child is gaining weight 66 kg at 16 years, and fever you have not documented. It is it is based on the parents, that the parents are saying the child is having fever. I have yet to see, parents always feel that their child is running fever. You should have documented it yourself. I mean, these could be stigmata of abdominal cocks, the bloating, the pain, etc. They can persist even after successful treatment. You yourself, you are saying that we did not find any on a repeat testing, we did not find any significant lymphadenopathy. I have a serious doubt about the PET report. Your PET report does not match with your reports. Do you agree, yes or no?
Yes, ma'am. That is why
है
patient
ना?
was
क्योंकि
symptomatic.
आपको जैसे हम लोग बोल रहे हैं, you should have got the investigations repeated, at least got a CT abdomen repeated. Ultrasound, I believe, is a subjective investigation. It may not show, well, like over here, it is just shown a simple ovarian cyst, which is not of any significance. It could be just because it's a young girl who's ovulating. Then minimal ascites can be there even with the ovulation, mid-cycle. And then there are subcentimetric lymph nodes on ultrasound. While your PET scan is showing us a lymph node of 4 into something, 4 into 1.2 or 1.7. And you are saying that you could not get hold of another specimen. I would seriously advise you, to go ahead and repeat all the investigations. And, if you find a lymph node, do an excision biopsy rather than true cut biopsies. Just remove that lymph node. Take the help of the surgeon, because this sample would be very important. The reports which you are relying upon, like the microbiologists who have guided us, Dr. Manpreet Bhalla, Dr. Ritu Singhal, and even in my opinion, your expert ultra is showing you, that there is MTB detected very low. And when we all agree that MTB detected very low can persist, minimum 2 years, maybe sometimes 4 years. And these are documented studies which are available, which say that expert ultra has no value after a full course of ATT. I do agree, your TDM levels were low. Now you have a CAT-G resistance on pyrosequencing. I would have gone ahead with the pyrosequencing and increased the dosages of the drugs for H monoresistant regimen, and gone ahead and followed for FQ resistance as well as for the other drugs, and then modified my regimen accordingly. TDM is showing so low. All the three drugs have come out so low: R, Z, and
E.
E. E. All the three drugs, they are so low. So you should have increased the dose. Maybe the child has got some intestinal, because of the intestinal TB. As a post-TB sequelae, also the absorption of the drugs, it's all known that absorption of drugs may be hindered, So, I mean, anyone else agrees with my line of management?
Madam, can I just, yeah, I'm
Yes,
Dr. Shikha Malik, ma'am, from AIMS Bhopal.
yes, please. Yeah.
Brilliant presentation, very confident, everything there. But you're absolutely right that most of the patients that we get in the OPD and IPD are actually having almost the same history. The parents are tired, 100 physicians, 100 different types of treatment are being given. Someone stops it, someone starts it, someone adds something, and then they talk about resistance. And very rightly, the count is very low. How can you have the resistance pattern for both INH and rifampicin? One. Secondly, if in a very low count. Secondly, all the clinical parameters were improving. So you still have to think whether to start all these reserve drugs, because we are also now watching that the number of patients is again increasing. Last decade, we saw a decrease. Now again, there is an increase, and the treatment has to be very strictly followed. The protocols have to be very, very strictly followed, a very good history. And sometimes when we say that the parents were very distressed, everyone is distressed, because if a child is suffering, you're already, I mean, you have to run from pillar to post. But sometimes I believe that a very strong protocol and guidelines should guide our treatment, rather than, because when you start this bedaquiline and everything, things become very messy. Now to ask them to undergo another treatment line, whether it has to be through the Ayushman or they are going to get all these investigations done, is a very big question. And of course, the weight increasing and everything, I still believe what you're saying is right. And I just wanted to know why the levels of rifampicin, isoniazid, and this thing paracetamide were low. If they were low, because maybe that the drug was not taken properly, did we check that the drugs were taken orally all right? Or how can it be low? And if it is low, which means that the absorption and whatever you're saying post stigmata of tuberculosis, then the other drugs that we are giving, that also should be low, because the drugs are not getting absorbed. How is it possible that all the three levels are subintimal and subminimal levels, and this thing, and then we go ahead with other drugs? So if there is of absorption, I think, and a very good this thing, one should have it for all these cases. I still believe that the institute or wherever should have a multidisciplinary committee to decide, and what we are doing today should be there in each and every institute, because it does give you a lot of exposure and a lot of insight.
Yeah, this is the precise purpose, of holding this pediatric TB eco. That is how we learn from each other. The purpose is not to demean anybody or to,
Of course,
we are all learning. Even I'm learning. I may be wrong. So we are all learning. And I think Dr. Urvashi, she joined in because I would like to even, have her remarks. Before we have her remarks.
There are certain questions. There are certain questions. We can take the questions.
Yeah.
So I just, there is one questions in the chat box in which they just want to know why the TDM level was found low at that time. So why the doses of the DSTB drugs were not increasing in this patient, and why this patient is directly shift to the all oral longer regimen. Basically, initially, you are treating this child when you find that INH was resistance in the pyrosequencing, then you shift this patient to the and pyrazinamide and lido and fluoroquinolones was also found not. Then you shift this patient into the linezolid, rifampicin, ethambutol, and pyrazinamide. Later on, the TDM was done, which was found low. So why the dosage of the DSTB drugs were not increasing in this patient, basically?
Sir, the doses, maximum doses were already given, sir. She's already taken that maximum doses.
But it's not like that, now you got TDM done. So the maximum dose is the dose which has been generalized, but that does not mean that you cannot adjust your dose accordingly. We have seen in children, sometimes you have to increase the dose based on the TDM. It's very good that you were thinking rationally, that you thought rationally that, because there is a comparatively poorer response. that maybe it is because of the low PK levels, and you got low PK levels. I would have advised, had I been the treating clinician, I would have increased the doses of those drugs, because you know that is documented resistance. You have a report which says catch G resistance, and you have fairly started on INH resistance regimen. Though I don't agree with you that, you know, FQ resistance, you have also thought of FQ resistance. So if you have, you know, removed levoflox and you have added linezolid. Okay, so you have taken that. I mean, but now with these reports, why the doses were not increased?
Actually, you
One
can.
more, sir, one more possibility we were thinking of was also heteroresistance, like whether she's harboring both the resistant and the sensitive bacteria also. And
No,
is that
that is the concept which we all need to understand. You know, whenever there is whenever we start the ATT, you know, that is the reason there are three subpopulations in a given patient. Bacteria which are sensitive to both rifampicin and INH. Then there are bacteria which are resistant to rifampicin. Then there are bacteria which are resistant to INH and other drugs. You know, so it is each and every particular patient, depending upon the number of courses the ATT that patient has received, or the bacilli. If this is a primary case of drug resistance, now it depends now from where was the source of this bacilli. So you know this mixed population is always there. So you were thinking rationally, and that is a thing which has to be kept in mind. But you know, this concern which even the house is asking, they are also feeling that you should have increased the doses of these drugs. And even I go with the house that once you have such low TDM levels of rifampicin, INH, and ethambutol, no, sorry, rifampicin, pyrazinamide, and ethambutol, you should have increased those dosages, looked for the response. Maybe the child might have improved on these drugs. You know, we are looking at a regimen of 6 to 9 months, or maybe going ahead if need be. And then, if there was no response, or there was, the patient deteriorated, that was the time I would have justified that, you know, you were justified to start the all oral bideckelin based regimen, and even taken that pre-XDR report, which is now coming not determinate. You know, we could have thought of that, you know, this report, because as our microbiologists, they have said, not interpretable report does not mean anything. It could be sensitive, it could be resistant. So the benefit of doubt.
One thing also I want to add that actually, ma'am, you started the linezolid by seeing the report of INH resistance, and fluoroquinolone report was not interpretable. So you started the H mono regimen, but in this regimen you can extend the dose of ethambutol 1200 milligram and pyrazinamide 750 milligram. Actually, you can get extended up to 2 milligram of ethambutol and pyrazinamide up to 3 milligram. So you can extend it the dose up to maximum dose. Actually, here you didn't mention the weight of the child. You only mentioned the weight band 46 to 70. So, any idea what is the weight at that time of the child when you started?
66 kgs, sir.
66 at that time.
66. So that is okay.
Okay.
There is
another question actually regarding the TDM and regarding the pyrosequencing. Actually, there is a question in the pyrosequencing regarding the sensitivity, gene expert and LPA, and with comparison with the pyrosequencing, which is more sensitive. So, can I take this answer from ma'am, Dr. Manpreet, ma'am?
Yeah, so Dr. Alok, these are actually different technologies sort of, because in the this NAT tests, yeah, CVNAT, or we are using a very short sequence of genes which we are, the region is very small which we are using, whereas in sequencing the larger region is used. So ideally this sequencing should be more sensitive. But again, as I told you earlier, pyrosequencing has its limitations. It's not It is more sensitive than the molecular other NATs, but it is not as sensitive as the whole genome sequencing or the targeted sequencing. So they have to, both the tests have, you cannot just do the pyro sequencing straight away. So first you need to do the NATs and then go, if you find whether it is either there is some discordance or you want to confirm, then we need to go for sequencing.
So, Dr. Manpreet, what would you advise in this case? I mean, are they justified in starting the bedaquiline-based pre-XDR regimen, or
Yeah.
on INH mono or poly drug? I would say mono, because SQ is not determinable.
Yes, I think Dr. Sangeeta, as you have pointed out, as well as the other experts have said, that all these newer drugs, we have to start with very caution. So we have to, there should be a committee which goes through in detail and we should have some microbiological confirmation before going for these drugs, reserve drugs like bedaquiline and delaminate. So we need to have a definite result. I feel that we should not start them immediately without any evidence.
So how long has the patient been on the all oral bedaquiline-based regimen?
4 months. 4 months. October. 5 months now.
अच्छा 5 months हो गए फिर तो now तो you will have to continue. Now you cannot go back. I was just wondering, if you're right in the initial stages, we can ask you to just go back to the H mono resistant regimen and look at for the response. But since you're already 5 months ahead, so I think now you cannot revert back. So any other question from the house?
Ma'am, may I ask some questions, please?
Yes, please. Yes.
Ma'am, my first question is there any possibility of co-infection with NTM in this case? Because due to the indolent course, patient was not deteriorating, but patient was getting positive tests throughout. But patient was not losing weight, patient was not very sick. So is there any possibility of co-infection with NTM? My second question is, ma'am, what is the high dose rifampicin that you can recommend if such TDM is there in cases? So how much should we give the rifampicin dose? How much dose should be increased? And the third the third opinion regarding this regarding the management, ma'am, sometimes happens. It is also I have two cases, and both of them unfortunately did not survive. Patients were extensive pulmonary TB, adult patients, extensive pulmonary TB, regularly losing weight. Sputum was positive, CBNAT was R sensitive, LPA was sensitive. We have the consultation with DOTS Plus committee. According to the advice of seniors, we put the patient on all oral longer, and even after putting the patients on all oral longer, patient did not survive. One patient recently passed away after taking 6 months of ATT. In this case, the patient is recovering and everything is getting now better. So I think this is my opinion. I don't. So I think this patient is recovering. So maybe we should complete this all oral longer case in treatment duration in this patient. So the first question is, ma'am, is it there is a possibility of co-infection with NTM? And second, what is the high dose rifampicin that you are suggesting? Thank you.
So you want me to answer? Yeah. So now coming to NTM. Over here, this is what I'm saying, that they need to revisit and they need to go. Please, can you mute? So, the most important thing is that right now there is no report which says NTM. Even Expert Ultra tells MTB. The initial expert CBNAT, which was done in 2022, that also says MTB. I mean, there is no report at hand which suggests that there is NTM. But obviously, I'm quite skeptical about the PET CT scan report. that one report is, does not fit into anything. Because I feel that with 66 weight kg of this child, 16-year-old, 66, I'm quite skeptical that is the child deteriorating clinically? I mean, that is my first question. Number two question is that even the radiological deterioration, their ultrasound tells that there is no lymph node, there is no ascites, there is just a simple cyst in the ovary. While the PET, which was done 2-3 months prior to this, it shows, a lymph node, mesenteric as well as mediastinal lymph node of the size of 4 into, I think, 1.2 or 1.7, which is a very significant size. And if you look at the chest X-ray appears to be normal. I mean, I would go take your investigations which you have done at your site. Your sputum smear is negative, your CB-NAT is negative. While this pyrosequencing, I would also like to ask you whether this was done from an accredited lab, because that also raises issues.
Ma'am,
Because
it was done from an accredited lab from Mumbai.
From Mumbai. Is there any microbiologist, Dr. Manpreet, Dr. Ritu, can shed us light?
Ma'am, I just want to make a comment. Accredited lab is important, but as far as sequencing technologies are concerned, still there are a lot of gaps in the very process of accreditation which is available for the sequencing technologies. So when you talk about your LPAs and CB-NATs and others, there is still a process which is in place. So that's another big issue, that even if it has been done, there is no system per se to check it. And system which is existing is not so proper. So you have to take it with a pinch of salt any which way.
So that gets you the answer of your first question. That could it be NTM? Right now there are no reports at hand which suggest NTM. Now coming to your next question regarding the dose of rifampicin. The highest dose which has been given in the HICON rifampicin trial was 40 milligram per kilogram. So and now in this case the dose has to be titrated. We have been giving, because poor response. The first thing, now with the availability of TDM, I would say that if TDM is available, please go ahead with TDM. Even we are getting TDM, and TDM levels, they come low. You increase the levels of the drug, and the patient starts to improve. So this is a very good investigation which is at hand now these days, and we need to take the help of this investigation. Regarding the low level, I would say the biggest question mark in this case is compliance. Since you have started the all oral bedaquiline based regimen as pre-XDR, because you're not giving fluoroquinolones, so you're presume that it is a pre-XDR case. I would say that please ensure that there is a treatment supporter who is available, who gives the drugs physically to the child. Because I have lost 3 children. Last time also I said, one child I lost, the mother was a school teacher and the child used to go to the same school. But because the mother used to give the medicine to the child, there was always a gap between giving the medicine to the child and the child swallowing the medicine. And we finally lost that child, and all that pile of medicines the mother got in the pillow after 1 month of the death of the child. So please ensure, because this is the last chance for this child. So please ensure that you have a treatment supporter.
Yes, ma'am.
Madam.
Yes, sir.
Dr. Rishi has raised hands for quite some time.
Okay, Rishi, can you? Okay, Dr. Rishi.
Yeah, madam. Thank you, ma'am. Madam, on listening the whole cases scenario, what I have got is that the culture was negative, and since we are doing gene expert ultra parasequencing, so and these are all DNA based tests. So it might be that the patient might have, so since the culture detects live bacteria and all that, these are it might be the dead bacteria DNA part, a small part or large part. This is my first observation. My second observation is that since the BMI in this case is quite high, but TDM is low, because I had presented a case last year in which BMI was quite low, 14.7, and it's the TDM was quite low of same medicines. And madam, my third concern is that can PT scan also shows the post treatment sequelae, because we don't know, because this PET scan shows inflammation. We don't know that this is a patient might have been cured, but its sequelae might is there. So that's why PET scan is showing so many this spots, fluorescent spots, madam.
So fluorescent spots, I mean, this is what I'm saying. Their reports, they need to repeat their investigations. I would suggest one thing, because if that PET CT scan is to be believed, and even the size of the lymph nodes, etc., the pleural nodules, and if they're showing metabolic activity, that means it's an active lesion, and that means it requires treatment.
Okay, ma'am. Okay. Okay, ma'am.
Ma'am, there is one question: can we we should continue the treatment, or we can shift this patient into the?
Now the patient cannot be shifted. This is the reason I asked how long the all oral regimen has been given. The child is already taken 5 months, so the intensive phase is just going to be over. Now, how are you following up this child? That is my question to you, because this will be very important, because the follow up for MDR and pre-extra regimens is always culture based. So, how are you going to follow up this child? You are saying that the child is improving. What criteria of follow-up are you following? Have you sent the sputum? Because the sputum culture, initial culture was negative, but are you sending the sputum culture starting from third month, every month till the IP is over, and then every quarterly? I mean, as per the protocol which is available. Please, because this is the last chance for this child. And
Yes.
and never think that initially it was culture negative. Maybe later on it becomes positive. So follow that protocol. Treatment supporter like a Nikshay Mitra or a treatment supporter, and because this would be the last chance for this child. The child has already been prescribed so many medications, outside, that you have to be very careful that at least the compliance has to be ensured this time. So, any other question?
Most of the
But this is a very interesting case, yeah.
As you already discussed regarding the compliance, they are also asking what are the compliance you are following in this patient regarding the BDQ regimen you are doing. So, as ma'am already discussed regarding this, once the patient is shifted into the all oral longer regimen, so compliance is very important. He is taking the all drugs or not.
Please arrange a treatment supporter, Yeah.
So most of the questions are already taken.
Shifa, can we have that algorithm slide? The last. I mean, we would like to sum up over here regarding the recent updation on the algorithm. इसको screen उसमें कर. So this is the integrated. I'll do it. Don't. So this is the integrated algorithm, which is now the integrated diagnostic and treatment algorithm for drug susceptible and drug resistant TB. And this will be out, because this is I picked up from the draft, but we are already out. I mean, by World TB Day, we will be out with these guidelines. So the first integrated is that whenever you have a notified TB patient, that means notified patient, that means diagnosed TB patient, but RIF resistance is not available. Or you have presumptive TB, like in this, in children where the chest X-ray is showing lesions and the child has got symptoms. And the last category are the children who are non-responders. So the first test which we do is we need to collect, for pulmonary, we need to collect 2 sputum specimens, and these need to be sent for NAT. Now the program is also starting expert XDR. So presently the expert or the NAT which is available, the true NAT or the gene expert, that tells us only of rifampicin resistance. But once with the availability of NAT XDR, we'll also be able to tell about the INH, FQ and SLI resistance and also ethanamide, because that's what we call as the expert XDR. This is already in pipeline and the program is already in the process of now procuring the and disseminating the expert XDR vials. So if it is RIF resistance not detected, then we all know the first thing is that we test for rifampicin resistance. If rifampicin resistance is not detected, the next thing is what we go ahead with the INH resistance. So INH resistance by first line LPA. So if INH resistance comes, as in this case, it came out to be INH resistance, that is CAT-G. So we have a separate regimen, that is the 6 to 9 months of without INH, that is rifampicin, pyrazinamide, ethambutol, and levoflox. But if there is a problem in availability of these loose drugs, so we can even give the RHZE, along with levoflox or moxiflox. It is levoflox resistance, and depending upon the severity of the disease, you can continue this regimen for 9 months. And then, depending upon if there is any additional resistance, that is, if there is any additional resistance to either pyrazinamide or to levoflox, then if either of the two, then you add, you replace these drugs and you add linzolid. But if there are both, that is pyrazinamide as well as levoflox resistance, then you need minimum 2 drugs. That is, along with linzolid, you need to add clofazimine or cycloserine. Clofazimine, is comparatively safer, so we prefer clofazimine. So this is the algorithm for RIF sensitive. Now coming to the RIF resistance, if it is detected, so the first thing which is taken into consideration is the age. If the age of the child is more than 14 years, as was in this case, now this child is 16-year-old, so the best regimen, the first choice of the regimen would have been BPAL-M. And irrespective of the status of moxiflox or levoflox resistance, under the program we are giving 6 to 9 months of BPAL-M. We continue moxiflox also. Now coming to the age of the child less than 14 years, now if the child is eligible for the shorter regimen, that is the 9-month regimen, that is BDQ based, we give bedaquiline 6 to 9 months. Now ethanamide has been replaced with 2 months of linzolid, and rest drugs are given 4 to 6 months, that is levoflox or moxiflox depending upon the resistance, clofazimine, pyrazinamide, ethambutol, and high dose INH. Now the criteria for starting this regimen are that your child should not be FQ resistant. If there is FQ resistance, this regimen is totally knocked off. The other eligibility criteria which need to be taken into account are that the child if has CAT-G or INH resistance but not both. And later on, if you come across the report which shows pyrazinamide resistance, then also this regimen, you will not be able to move this regimen forward. You will have to shift the child to the long all oral MDR or XDR TB regimen, and depending upon the sensitivity, initially we start with, we try to include all the 3 group A drugs and 2 group B drugs. So 5 drugs initially are more than enough, but this needs to be modified based on the DST report, which will come on later on once you have started the long all oral regimen. So this is in nutshell, the algorithm which is the integrated diagnostic and treatment algorithm for both drug sensitive as well as the drug resistant TB, which now the program will be following. So with this, I think we come to the end of this session. Is there no other questions?
Yes, Dr. Puri.
Dr. Puri?
Dr. Puri, sir, can you have any question? Dr. Puri, sir, have you any question? Actually, we saw your hand was raised. Okay.
Okay. Anybody else wants to ask any question, or we close this session?
Can I make a comment? Now I'm here.
Yes, Dr. Puri.
And Dr. Sangeeta, the question is regarding that many people are asking, and every time, what is the relationship between the therapeutic drug monitoring? Because we have a machine which give you the blood level. We do not know whether they are really low, because most of the people, most of the TB patients, they are responding to the drugs which are used under the program in the doses which they are given, but there are only few patients who do not respond. We do not have any data regarding the blood levels of these drugs in the patient who have responded. So if we should have a study, the patient who have responded, what was the blood level?
खराब हो
And
जाएगा
then we
भैया,
can
को घुमाओ
compare
मत,
with
चेन
that.
खराब हो जाएगी सारी।
Pardon?
निकालो उसको, निकालो ना चेन लगा के, पेपर लगा के।
Please, can you put it on silent?
So we should have that data also. Only then should be able to say that these are really low drugs, and then we are unnecessarily giving them a high doses. And we have given the high doses, but result was not very satisfying in those patients where the doses were increased. And most of the time, I was asking that we should present those cases also where the high doses were given, so that we should know whether they worked out or not. But we have to ultimately switch over to the Bidaclid. So lot of research is required on the therapeutic level of these drugs in the patients who are responding also, so that we should have some data that what is the normal values here. Because what we now say is the data which is given to the machine, that this is the value which is up to this is normal, below this is subtherapeutic. So I don't know how to correlate the values with the clinically, whether they are low or we should give it or not. But I have seen that some of the patients, they respond with these doses in the beginning, and later on they relapse or they fail, and then the drugs levels are low. So why they have responded in the beginning? So in some cases, my point is that they responded, but they fail because the total duration is 6 months, which may be a longer duration in those cases because they have a disease which is extensive in nature. So they may require a extensive treatment of 6 to 9 months in those cases. So for individual cases, if the patient is not responding or radiological clearance is not there at the end, or the physical signs are present at the end of the 6 months, the treatment should be extended there, and a culture should also be done. In most of the cases, culture is not done, and then the patient came back after 1 year or 6 months within a year, and we think it is a relapse. Actually, it is not a relapse. It was the incomplete treatment for that patient. So 6 months is adequate for majority of the patient, but few cases which we are discussing here, it may not be adequate for a few cases. These are rare cases, and we should manage these cases accordingly. So patient workup at the end of the treatment should be there. As per the guideline, we have to do a culture, but we don't find any patient who have a culture at the end of the treatment. And whether it is a culture negative or not, sputum is negative, whether it is fully treated or not, that we should take.
Yeah, that is a very important point, Dr. Puri, which you have highlighted. And the other important point which Dr. Puri has highlighted, that the monitoring of MDR TB is always culture based. Remember this.
No, Dr. Urvashi, I am highlighting the point that we should also have
drug
level of the patient who are responding, so that we should say that those who are not responding, they are really subtherapeutic or not, because when we have given them the higher doses, they have not responded. So it may be that because of the nature of their disease, that they have extensive disease, or some other reason they are not responding, and when we change the regime, they respond very well. So we should look for from those point of view only. And secondly, regarding in this case, when they were looking for the bedaquiline based regime, then it should be the prerogative of the treating physician to see that if the patient has taken the adequate treatment of drug sensitive TB and he's not able to prove it as a drug resistance, but the patient is still he is suffering from tuberculosis. In that case, he can declare the patient as a clinical failure of the drug sensitive TB case and switch over to the drug resistant cases. That should be considered always.
Dr. Puri, your points are very well taken, and I think that's a good PG thesis topic which you have suggested. You know, those patients who have improved, and we need to also know titrate their blood levels. You know.
Yes.
So, so now I pass it on, as we do not have any other questions. Now I pass it on to Dr. Dhulika.
Yeah, so with this, we come to the end of the 10th Pediatric Eco Clinic. But before we close, I would like to invite Dr. Ashok Bhardwaj, Chairman of the National Task Force, for his closing remarks. Over to Dr. Ashok.
Thank you, madam. So I listened the case from the start. So this case reminding me of a case in Himachal district, Kangra, about 3 years back. Same. The age was at least 4 years younger to this case. So they went everywhere, to Jalandhar, to Ludhiana, to Rohtak, everywhere. Then spent a lot of money. Then they came back to the public health system at Kangra, and the patient recovered. So somehow, Sangeeta, we see that each difficult case discussion, whether it is pediatric case, whether it is adult case, guidelines, they are being compromised. So if we also look into this case, had this case been tackled as per the SOPs, as per the national guideline of NTEP, the case might not have suffered. So perhaps I don't know whether the tests were approved by scientific division or not approved by scientific division, but we must go as per the guidelines. So yes, wonderful presentation by Shreya and Dr. Pragati. So hope this case will improve, and why, as somebody told, as Dr. Puri also told, yes, when I was in Tanda Medical College, we did therapeutic monitoring as a project. But Sangeeta, I must confess here that even when the levels were low, the patients were improving.
Yeah,
so we must look into Dr. M.M. Puri's comments, and we should go do something in this respect. So thank you very much. Thank you for giving me a chance. So hopefully we reached 150 today. So if we go with this, it is a wonderful CME, and I am learning by each episode. So thank you very much.
Thank you, sir. Thank you so much for your encouraging comments. So with this, we close today's Pediatric TB Eco Clinic. The next Pediatric TB Eco Clinic is scheduled for 18th of March 2025, and the presenting team is from AIMS Rishikesh. So I hope to see you all on the third Tuesday of March, that is 18th March, for another interesting case discussion. Till then, goodbye.